right, good morning. It's good to see you right here on Your World. We are outside, and today's Mindful Monday. And as you all know by now, on Mindful Monday, we discuss topics that matter to each and every single person of us. And today we'll be taking a pulse check at our healthcare system and just getting to understand where are we, what is it that is not working, and what is it that needs to work to ensure that every single person, according to our Constitution, have access to quality healthcare, but at the same time also look at the power of partnerships and what can be done to strengthen our healthcare system. So it's going to be an amazing conversation, and we're coming to you from the Aga Khan University. I'm just going to be careful here on the stairs lest they fall. But we're coming to you from the Aga Khan University, and specifically on the Center for Innovation and Medical Education. And they've been kind enough to host us even as we hold this very important conversation. And even our panel are already here. But we also have an amazing audience amongst us this morning. And we'll also be engaging them a little bit later as we continue with the conversation from different, entities and organizations to just get to see how we can improve our healthcare systems right here in the country. My name is Winnie Lubembe. The show is Your World. You want to stick around until 11 a.m. when we'll be having this conversation. But to introduce my guest for the day, on my immediate left. I always have to do this right and left, okay? On my immediate left, we have Mr. Rashid Kalani, who's the CEO of Aga Khan University Hospital. Good to see you, sir. How are you doing?
Thanks for having me. I'm doing well. Thank you.
I should say thank you for having us because we are in your home. If you decide to chase us, we will go, okay? And we also have Professor Eunice Ndirang, who's the Dean, School of Nursing at Aga Khan University Hospital. Good to see you. Good to have you. How are you doing on this Monday morning?
Good morning. Thank you for having me.
And thank you for joining us on this important conversation. And we also have Dr. David Kariuki, who's the CEO, KMPDC. Good to see you. Good to have you this morning. I know you just settled, but how are you?
Right, I'm fine. Pleasure to be here.
Okay, fantastic. And it's great to have all of you here with us today. And like I said, we also have an amazing audience, which will be giving them an opportunity to also contribute into what we need to do to ensure that we strengthen our healthcare systems right here in the country. But before that, I'm going to ask a question. This is across, all three of you, in terms of understanding where we are at as far as our healthcare system is concerned, how far we've come, what is it that we need to do. But we'll talk about the challenges and the gaps and all those things later. But from where you sit, Mr. Rush, let's start with you. Where are we?
Should I go first?
Yes, please.
Okay. Okay. Thank you. I think as far as Kenyan healthcare is concerned, we have come a long way. There has been big strides that we have made. So I'll give you one example. The life expectancy has grown from 40 to 63 in the past 2 decades. Okay. So that is improvement. The infant mortality under 5 has reduced significantly from 143 to around 40 in the past 10-15 years. So that is significant change. Right. I think both public sector, private sector has made significant investment in facilities, in human resources. That's why we are seeing a lot of improvement in the healthcare landscape. However, there are 2 areas which I feel that requires improvement. Right. The first is the divide between the urban and the rural area. If you look at the most investments that the private sector is making and even the public sector is making is in the urban areas. If you go into the rural areas, I think there is the human resource capacity is not as such. So I think we need to invest in our rural settings more. All right. And the second area of improvement is the manufacturing base. If you look at the medical devices, they are all manufactured outside. If you look at the pharma, it is around a quarter of it is manufactured locally. Most of it is imported. And what does that mean? That we have to import, we have to pay dollars in order to import. That pushes the cost of healthcare higher. And also what we saw during the COVID pandemic is when the supply chain was disrupted, because nothing was manufactured or very little was manufactured locally, we were at the mercy of the other countries. And we were not the only ones facing COVID. Other countries were also facing COVID. So they had cut down the supply chain. So the boundaries were restricted, the imports were restricted, and we as a country and countries which were not manufacturing, which does not have manufacturing bases, they suffered significantly. Okay. So I think these are the 2 areas for improvement.
I see. And we'll have a representative from Roche in our audience, which will be, interacting with them a little bit later from the production side, just to see how then can we improve, that whole aspect of our production. Prof, where are we? How are we doing?
I do agree with Rashid. Lots of improvements, huge milestones. I think for me, the big one is the change in the healthcare models, an emphasis on primary healthcare, bringing health closer to the people, and making universal health coverage a reality for many. I also believe that the quality of training in Kenya is pretty good, and I believe that is why internationally, for instance, nurses are very highly sought after. I think those are two critical things that are important, because if we do not have good quality trained nurses or doctors, any healthcare professional, then we will not be doing well. The areas that I feel need improvement, of course, we still have a lot of areas where there's very poor infrastructure, and you will not be able to provide quality healthcare if you do not have adequate infrastructure, both in the public and private sector. Another area that requires, that's a challenge that needs to be looked into is, of course, the distribution. For instance, we can say we have 1,000 critical care nurses who are trained to provide critical care, but you may find maybe 90% of those are located in Nairobi, and the rest are shared across the other ICUs in the country. So that balance of where our trained specialists is something that is actually a challenge that is impacting on the state of healthcare in Kenya.
And then we'll come back to understand. So then how do you, both as Mr. Rashid and as you, Prof, and as Aga Khan, from the private sector, contribute towards ensuring there's that balance? But let's speak to KMPDC regulation. Where are we? How are we doing?
Thank you very much. I believe as a country we have moved a lot for the last 60 years, considering that maybe at independence there were very few health facilities, and probably only public. Today we are talking over 17,000 health facilities across all levels, from dispensaries to the tertiary hospitals like where we are. And it's a mix of nearly half-half, public and private, meaning that we have really grown, and access to care has improved for very many of our people in the population. As my colleague said, our life expectancy has gotten better, infant mortality is better, but there's still so much that we need to do, in terms of health, workforce, and the nursing has already been mentioned. We have now currently in our register over 17,000 medical and dental practitioners, so available as a pool to be used across the country. Everything comes with its good and bad. We have the devolution as a mode of governance in the country, and it has partly brought services closer to the people, not as much as we would want or expect, but it's still a step. For example, at the time of devolution, Wajir County in the northern part of Kenya had only 2 doctors. Today, I was there 2 months ago, they have 65 doctors and many more nurses. When you talk about that, probably they have tripled the number of nurses. They may still not have enough. In fact, they have the first psychiatrist in northern Kenya, such things. So basically, we have had some improvement, but there's still so much more to do, especially in reducing the costs of care and access, to the population. And I think those still work in progress. Right.
I mean, I was about to ask, it's good that we're starting on a positive note. We're very optimistic in terms of how far we've come and what needs to be done. We've identified a few of the gaps here and there. But someone who's watching us at home might think, so you're talking about, yes, we've come a long way. There have been a lot of improvements that have been done, which is good. But almost every single month, we see doctors on the streets. We see nurses on the streets. Just recently, we had dentists on the streets, and there's no one to really attend to the people. And so I might ask, what exactly is the biggest problem? Because if we've dealt with some of, those issues that were impending in terms of quality of care and people having not access to, but at the same time, we still have the same people who are supposed to attend to these people on the streets and not in hospitals. So where exactly is the disconnect?
Maybe I would say largely it's in planning and implementation. we may be having disconnect, probably between the production of health workers, health workforce. As we say, maybe if we have like 3,000-4,000 doctors who are not employed but have been trained, you are probably talking of 30,000, 40,000 nurses, many more clinical officers, many more laboratory officers. So if we could have a good plan in terms of, as we train, we have a plan on recruitment, deployment, retention, and working environments. I believe most of these challenges that we are having would be reduced.
All right.
And, you know, for that requires adequate funding. And we believe that as we improve our health financing systems, some of those may become challenges that will be surmounted, but it requires, you know, maybe some faster resolution of those challenges. Yes. Yeah, you know, because we are probably using the same systems we were using 20, 30 years ago, where we were only producing maybe 100 nurses, or let me say 100 doctors, 400 nurses, and we would absorb all of them. Today, we are producing over 1,200 medical practitioners per year, probably 3,000-4,000 nurses I may not have, and many more other, you know, health professionals. And without an adequate plan on how we are going to retain them, we get challenges, because also not very many may be able to leave our country, you know, and there's no need of training without, and then allowing them to just go. We would only want those who want to go because they want to go, not because there are no opportunities for them in our country. As you know, we have moved from a stage where we had only one medical school, for example, to currently 13, including Prof and the team here. You know, many more, probably high number of nursing schools. Probably there is no county nearly without a nursing
I'm curious college. To hear what Prof has to say.
It is true, we are training a lot more. We find sometimes we graduate, especially for nurses across different cadres, between 6,000 and 8,000 a year. So we do not necessarily have a problem with production. I think we have a problem with absorption. And it is important that we ask ourselves critical questions around who are we training for. If you go to a health facility in some county, you will find while they have increased number of nurses and midwives, they actually are still not having adequate patient to nurse ratios. Some are really, really, you know, really bad. You can go to a ward and find you have one nurse or two nurses against a ward population of about 40 to 60 patients. So we do have a problem of absorption. The second issue around here, again, is to do with remuneration. We are not paying nurses and doctors and any other healthcare worker enough to remain where they're needed the most. And that's at the primary level. You're better off having a very well-trained nurse, a very well-trained healthcare professional at a place where you do not have a lot more doctors, for instance, or where the populations are not well served, so that that person is able to make an impact in that you know, level of care. So we need to deal with those both issues, the issue of absorption, but also the issue of paying the nurses well enough to remain where they are needed the most.
I see. At least ensure that they are happy, because they are dealing with people. And we'll come back to understand then. When you say enough, all right, pay them well, what exactly does that mean? Because someone was actually saying, you see, it doesn't matter how much money you give someone, they will still say it is not enough. So when we say pay them well or pay them enough, what exactly does that mean, and how do we get there? But at the same time, you mentioned a little bit about cost and how cost of healthcare is expensive right here in the country. And even during the strikes, we saw a lot of patients actually opting to go to the private hospitals. But at the same time, they say private hospitals is also very expensive. And Mr. Rashid, this is a question for you in terms of how do you as Aga Khan balance that, offer quality of care? Because we all know that Aga Khan is really well known for that in terms of giving quality of care, but at the same time balance in terms of affordability.
It's a very interesting question and a difficult one, and it's going to be a long answer. There are many parts to this. The first is, like my colleague Eunice said, that if the doctors and the nurses are not paid adequately, if they are not able to have good quality of life, they would leave, or they would not want to work. So you have to pay your human resources well. Paying human resources well means high cost. The second aspect of healthcare is quality of healthcare.
Right.
At Aga Khan University Hospital, we have a very uncompromising attitude towards quality. We were the first hospital back in 2013 to get Joint Commission accreditation from US. The regulator did not ask for it. The ministry did not ask for it. There are 1,300 standards as part of Joint Commission. But it's the right thing to do as far as the patient care is concerned.
Right.
And we have many other certifications. There is a long list of College of American Pathologists, clinical certifications for our stroke program, for heart attack programs. We invest 130 million shillings every year on quality. It comes at a cost, so that we can provide good outcomes to the patients. So that's number two. Number third thing that I mentioned, we are the only hospital, I believe, we are the only private hospital, I believe, which is a teaching hospital. So we train doctors and the nurses who are then going back to the communities to serve. The example Professor Kariuki mentioned, that there are doctors in Garissa and other parts of the country. Where are these doctors coming from? They are coming from some med schools. And Aga Khan University, we are very proud that we have a med school, and we are training the doctors who can actually go out to their communities, to their counties, and then start serving the population in those areas. The academic programs, medical college or school of nursing and other research institutes, they are not cheap. The hospital spends close to 1.3, 1.4 billion shillings every year in training doctors and the nurses. So all this comes with a cost. However, then the question about the affordability. We have, within Aga Khan, we have patient welfare program. People who are deserving and cannot afford, we treat them almost for free. We spend close to 400 million shillings every year on patient welfare. And apart from that, we have 50 plus outreach centers. And in those outreach centers, we are very deliberate that the cost of care is 20, 30, in some cases 50% lower as compared to the main campus. And they are embedded in the community. So the idea is to take the care closer to the homes of the communities and also to provide cheaper care as compared to the main campus, because not everyone can come to the Third Parklands, Nairobi. So there are many facets, as I mentioned, in terms of cost, in terms of quality, but it has to work together. Everything has to be in sync for it to work. Otherwise, we would also see strikes, unfortunately.
It's true.
But we are not seeing those strikes because we are paying our people well.
Yeah. Okay. Prof, would you agree? You've been paid very well. Okay, not to put you on the spot.
You'd have to pay me extra to respond to that question.
Okay. And we've had a lot of the times people say, yes, we have doctors, yes, we have nurses, yes, we have medical professionals in the country, but there's that aspect of, do we trust them to offer quality, right? And that's why we see a lot of people actually traveling abroad to seek medical care, and yet we have very qualified, like Dr. said, professionals right here in the country. How do we help in terms of changing our attitudes towards whatever we have in the country as far as our professionals are concerned?
As I had said earlier, the fact that a nurse trained in Kenya can get a job in some international facility in the US, globally, wherever the case might be, is a reflection of the quality of training. But we also have to have an honest conversation and ask ourselves very critical questions around the numbers we train and how we are training them. We are seeing a move towards everybody wanting to have, for instance, a training medical college in their constituency, in their towns and in their city. And that comes at a cost. Because at the end of the day, you can only train so much without diluting the quality of the training. So that's the first thing. So we have to be very mindful of the fact that if we dilute the quality of our graduates, we are actually directly going to affect the quality of care. The second angle to this, and this is a conversation we usually have a lot at AKU School of Nursing, is who is a good nurse product at the end of the day. the emphasis on too much content and very little on those other things that make one a good health professional is also something we need to think about. Sometimes a lack of trust comes because maybe communication, as you offer care, is not done appropriately. Maybe we are not thinking about getting our graduates to be problem solvers, to be critical thinkers, to come up with innovation that helps deal with the realities of our healthcare system. We have to be honest that resources are limited, but that doesn't mean that you cannot provide quality care within the realities of the healthcare system. So you'll find our programs at the school are very, very mindful of helping our graduates think through practical solutions that will help the care that they give at any corner of this country to be of the standard that it needs to be.
I see. And just to piggyback on what Mr. Rashid talked about earlier on in terms of the imbalance between the urban and the rural settings as far as either provision or affordability or even accessibility of healthcare is concerned, how big of an impact is this from where you stand, Dr. Hari?
Well, a well-trained, qualified health professional can only utilize their knowledge if they are given the right environment, which will mean that you give them the right health products and technologies, equipment, support services, whether it is radiology or laboratory, for them now to be able to provide the best care that they can be able to give. So when it comes to urban rural, that profession also looks at many other things beyond them just providing care. Where will they get amenities like schooling, banks, what? So they look at all those things. So we also need ways of attracting and retaining health professionals in the rural areas. How do they even advance themselves professionally when you look at the places you are trying to take them to work? We do have very good, very well-trained professionals, I can assure you. Like, for example, at the KMPDC, we are the first regulator in Africa to be certified for, registration of health professionals, meaning that our professional, if you have a registration certificate from us, it is as good as anywhere else in the world. And just to mention that for all the years we have been there, we have never received a professional back sent home because they were not well qualified or they are not able to provide services. And that's across all regulators in the country because we keep monitoring and talk to one another. So we need to find ways of how to retain the professionals in all places. And we have gotten much better in this country. For example, as of last year, inbound visits by foreigners into Kenya for medical care have moved from about 4,000 to 5,000 10 years ago to currently 10,000. That tells you how well we have improved our system, and the system cannot improve if it does not have the right quality health workers. So I think we also need to create more awareness among our population that just going out there does not necessarily mean you'll receive better care. Probably it's an issue of like us improving our waiting times and maybe the other softer skills that were mentioned. And we as regulators, including KMPDC, actually changing or making changes to what we call the core curriculum to include other issues outside of the profession, like communication skills,
people skills,
those others, so that we just don't, do just
produce people for the sake of. Let's take a break, and then when we come back, we'd want to understand because we've set ground in terms of what exactly is the issue. So human resource cost is also a very big issue. We talked a little bit about partnerships, but we also need to understand how better do we strengthen these partnerships to ensure that people get, the quality of care that they need, and this is enshrined in our constitution. But we'll also be engaging our audience as well, just to hear from them. What is it that we need to do better? Come 2 years from now, I don't want to say 10 years from now, 2 years from now, what sort of conversations do we need to have as far as our healthcare system is concerned? So be sure to stick around on the next 30 30 minutes of this conversation coming up after the short break. But if you're watching us from home and you also want to be part of the conversation, our socials are at NTV Kenya, both on Facebook and on X, and tag me as well at Lubembe_Winnie, and help us understand how do we improve our healthcare systems right here in the country. See you after the break.
Taarifa Teke na e-paper. Stay in the know on the go. Getting the full story Bilangori. To sign up, choose your preferred subscription. Use the promo code SUBZ22 to get 20% off and pay. Get your favorite newspaper and enjoy the truth anywhere, anytime. For inquiries, email epaper@ke.nationmedia.com or call 0790 111 111. Subscribe today and get your Taarifa Teke.
Mahali ya kusisimua na yenye mvuto, kutoka mashinani hadi mijini.
Zaidi ya madaktari 200 wameweza kuanza mgomo wao rasmi.
Serikali ya kaunti inaendeleza miundombinu kuhakikisha kuwa maji inapatikana kwa urahisi.
Ni chimbuko la habari zinazokuhusu wewe.
Kupata ID, sisi tulikuwa kama alias ambaye wamekuwa discriminated.
Michebebe is very nutritious, very chlorophyllous, very delicious, but less malicious.
Bila chuku, bila upendeleo. Taarifa halisi na asilia kutoka kwa wananchi kwa ajili ya wananchi.
Ndilo kero la taka ambao umeshuhudiwa katika mji huu wa matunda.
Kama serikali hawajachukua hiyo hatua, sisi wa Orma tutachukua hatua.
NTV Mashinani, kila siku ya wiki saa 12:30 jioni hadi saa 1 jioni.
Aiden, please, ongea na kakako, please, mwambie punguze hasira.
Hivi unajua ni mama's boy wangapi wamekuwa kwenye haya mahusiano and they never work?
Umefika wapi?
Do you know how difficult it is to balance these things? Huh? Are you out of your mind?
Nakuja hapo na Cecilia. You better watch out.
When I have back pain, I reach for 2 tablets of Panadol Extra. For fast relief of strong pain, like headache, toothache, muscle pain. And I am finally released from pain. Try Panadol for fast and effective relief from strong pain. Now available at an affordable price.
I'm a clinical director here and I look after everything regarding the patient's consultation, ultrasounds, the procedures, IVF, and everything is available under one roof with all the latest facilities. And we have been running this center successfully now for last 3 years. There are a lot of tubal blockage cases which require IVF because once the tubes are blocked, they cannot have natural pregnancy. So a lot of people don't know that it's available. And then there are a lot of other issues like the young girls who are studying and who are delaying pregnancy for whatever reasons. We want to create awareness amongst them that the egg freezing is a very good thing to stop the biological clock. We decided to participate in this because we wanted to create awareness amongst the people as well as the health professionals that the sexual health and the treatments for infertility, etc., the advanced treatments and the specialized doctors are available in their country. Everybody should attend this kind of health summits so that they are aware about the things that are available. We want to basically offer them treatments at the affordable prices so that they can have their families and they can live happily.
Welcome to Sun Park Residence, a pioneer gated community on Chadi Road, off Mombasa Road, just 800 meters behind Gateway Mall. Discover spacious 1, 2 and 3 bedrooms ready to occupy and off-plan apartments for sale, starting at just 6.5 million shillings. Contact us on 0793 444 222 to book your unit.
All right, welcome back. It's 31 minutes past the hour. The show is Your World right here on Mindful Monday, and we're coming to you from the Aga Khan University this morning, the Center for Innovation and Medical Education, and we're having a very important conversation as far as our healthcare system right here in the country, and we're reflecting on how far we've come, yes, but at the same time, understand, the quality of care and professional standards in terms of healthcare provision right here in the country, what needs to be done, and what are some of our strengths and how do we leverage on our strengths to make sure that even my grandma at home, when she needs medical care, she doesn't have to fly all the way to Nairobi to access it, okay? And like I was saying, if you're watching us at home this morning and want to be part of the conversation, our socials are at NTV Kenya, both on Facebook and on X, and tag me as well at Lubembe_we need. Let's get to understand how do we improve our healthcare systems right here in the country. And my guest, Mr. Rashid Kalani, who's the CEO, Aga Khan University Hospital. We also have Professor Eunice Ndirango, who's a Dean, School of Nursing at Aga Khan University Hospital. And we also have Dr. David Kariuki, who's the CEO, KMPDC. But at the same time, we have a lovely, lovely audience with us this morning and representing different entities and institutions. And I want to engage them right about now, just get to understand from where you sit, where are we, how are we doing? But at the same time, I'd also want to speak to a few staffers here. Not to put you on the spot because I know your CEO is here. But whoever wants to go first in terms of the contributions that we've made right here in the country, where we are at and what we need to improve on. Who wants to go first? Okay, fantastic. We have a hand over here. So yes, we have a mic. So please just share your name and yes. Yes, you can. Okay. All right.
Hi, everyone.
Good morning.
My name is Jemima Kimeu. I'm the Chief Nursing Officer at the Aga Khan University Hospital, Nairobi. I would like to just speak a little bit on nursing, just to expound on what Professor Ndirango has said. As we know, nursing or nurses are really the drivers of quality. We as nurses, our training or our profession is really so central that we are the persons who spend a lot of time with the patient. And for us to deliver quality care, we need that environment that is supported with training, which we are doing a fantastic job as a country. But more than the training, we need other supporting things like supplies, equipment, and then most important, the ratios that Eunice talked about. It's very, very difficult when a nurse is taking care of 20, 25 patients to maintain a smile, to provide quality, and not just the patients. If you have 25 patients, you can talk of 25 family members or more. So at the end of the day, really that nurse cannot provide the quality of care that we are talking about, and safe care. Because when your eyes are with this patient, you don't know what is happening with the other patient. So as a country, I think we have moved quite a lot, but as we are producing nurses, I like what somebody said, one of our colleagues, about the absorption. We must be able to plan and absorb nurses so that then those ratios can be less. Private hospitals today, they do a good job. In med-surg, you find a nurse is taking care of maximum 6 patients, and then you can hold them accountable for smiling, for safety, for all those things that we want a nurse to do. But honestly, 25 patients, even that smile.
And you know, I actually had a special question for you. I did not want to call you out. I wanted someone to speak, and then, because you see, most of the times when you think about nurses, ask anybody who's watching at home, they'll think mean, they don't have time, they're always angry.
So yes, we we also need that training, as we said, of the softer skills. That I totally agree. There is a lot of focus on the technical side of things, but we also need to emphasize on patient experience. It's important when patients are healing, they also walk out of that institution with a positive experience. That I must agree. But yet, we need also to support the nurse. And it's not just the nurse, it's the same thing with physicians, doctors. When you are taking care of too many people, it's very, very difficult for you to maintain even that professional behavior, because you are exhausted, you are tired. So my hope is that as a country, as we produce people, there will be a plan, as our colleague said, to absorb people and especially focus on the rural areas. Today, if you go to some rural areas, you will find a nurse with a whole ward of 50, 60 patients. It's very, very difficult to care of and talk of quality and patient safety in those circumstances.
I see that. And not all nurses are mean. They're good ones.
We are not mean. We want to be provided with what we require to produce, and then now we can be happy when giving care to our patients.
Others. I like that. We also have the Chief Medical Officer, Dr. John Weru, with us this morning. Yes, so let's pass on the mic to him. Earlier on, Dr. said, entice, attract. Find ways to attract doctors to go and work in those places, in Wajir, in Mandera, in Turkana. Yeah, I think it's...
You can hear me now?
Yes, fantastic. Yes, we can.
Thank you. And thank you for this conversation. And I think, Dr. Kariuki, you've talked about where we are as far as training is concerned, and also the number of doctors that we are producing. And I'm happy that healthcare within this country is domiciled within the Constitution. Look at Health Act 2017. Look at the Constitution itself saying that we devolve healthcare. Now, I believe, Dr. Kariuki and the panel, the discussion here should be what is the duty of care by our healthcare providers and what is the standard of care? How do we make sure that the standard of care cuts across, even as we talk about our healthcare providers being professional, being empathic, being compassionate? Dr. Kariuki here have said that our doctors are never returned to SEDA. Eunice, the chairperson of Nursing Council of Kenya, can also tell you that nurses are not sent to SEDA. So the placement that we have is good, but how do we now make sure that they go out there? We go out there, and the placement that we have for our nurses, a nurse is trained, for example, to do maternity work. Do we make sure that they go to maternity, not to psychiatric placement? As we train our doctors also. Yes, it's true, we face that. And because of that, if we don't make sure that what we train and the skill set that we have for them are being utilized for the patient to require it in a specialized manner, then mentorship and building of capacity might not be assured. However, we are happy that as a country, as it were, we have a very strong network, and let us call it intraprofessional and interprofessional, multi-professional approach to the care that we provide. And we hope that this will move not only in urban centers, as Rashid was saying, but also to the grassroots. As an institution, that is one of the core values that we espouse, that a patient care has to be multi-professional, multi-dimensional, and we hope that this will cut across the country.
I see.
Thank you.
Thank you very much. All right. Anybody else? Okay. Can we pass on the mic to him very briefly, and then we come back to the panel?
Thank you. So my name is Khurram Jamal, and I'm the Chief Operating Officer at the Aga Khan University Hospital. So
do you understand here so that the people at home can see you? Yes.
Sure.
Great. Thank you.
So the West is rapidly moving into spaces of telemedicine, telehealth, and the home care programs. So can you talk to us a bit about these two entries and how that will change the delivery of care in our part of the world?
Fantastic. All right, Mr. CEO, do you want to take that? And then...
I'll take it all the regular.
All right.
I'll take it. It's an interesting question and something that we think about and work on a day-to-day basis. I think technology is changing every domain of life, not only healthcare, but also the way we are served food in the restaurants, or the way we are taught in the schools or in colleges, etc. Technology is playing a big role and will continue to play a big role. At AKU, we have implemented the electronic health record system 2 years back. What is electronic health record system? It is that now all patients, be it within the main campus or its 50+ outreach centers, their patient charts are electronically available. So a patient who is seen in, let's say, Embu doesn't have to come to Aga Khan with a box file or a paper file. The mobility is very easy. But now that system will allow us to do many things. First is we can educate our residents and our doctors on electronic data. We can use that data for research purposes. And then we can use that technology to implement new solutions like the telehealth, like digital pathology and the likes. And we are moving in that direction of embracing technology. Last year, we have just started our home health program, which is growing leaps and bounds. And it is not only it's not about a technology question. I see it as an ethical question. If a patient can go home after 2 days and can be provided care at home safely, I think we should send them home. So home health program is not only about technology, but about the continuity of care for the patient and ethical care. And these investments will continue at Aga Khan.
All right. And Prof, also to tie in, if you want to add on to what Mr. Rashid has said, in terms of also the policies that are existing right here in the country, do you feel they support what we're talking about today essentially, and that is providing good quality care for everybody, doesn't matter where they are?
I believe Kenya has very good policies. We really do. And a lot of them address quite a number of areas that we are discussing here today. I think sometimes the disconnect is in the implementation. Because to implement some of those policies, you need the resources we've talked about. You need adequate human resource for health. You know, you need adequate equitability of many other things, not just the healthcare workers, but also the facilities that are available. So for instance, if you look at the quality care certification framework, it really does address the issue around the quality and how do we certify, how do we license, how do we ensure that that health practitioner we are talking about is actually registered by the relevant regulatory body. So from a policy perspective, I believe we've done quite well. There's still more to be done, particularly in response to the emerging technologies that are there. How are we going to handle AI, for instance, as a mode of delivery of care or diagnosis? And as a very close colleague of mine likes to say, AI can be used, say, for instance, for diagnostics. But what data does it have? It probably doesn't have enough parameters of data from this part of the world for it to make accurate diagnosis or accurate decision-making process. The other element around policy is thinking through how we entreat some of the key things that we're talking about. For instance, evidence-based practice and using data for decision-making. What policies exist to encourage that? What do we do in terms of thinking about how we teach, for instance? So at the School of Nursing, for example, for us, we look at the policies that are there within the government and international ones as well, and leverage on them as both a catalyst for how we teach and what we teach, but also as a way of getting our graduates to be at par in knowing what is going on. If you get into a health facility sometimes today and ask a nurse, a midwife, or a doctor, or a technician, what is the current policy on 1, 2, 3? Chances are they may not be aware of it. So that idea of lifelong learning, so that even if you're not in a classroom and you have graduated and you're in practice, how are you keeping yourself at par and aware of the policies? Because they will affect the practice, and they're supposed to lead practice.
I see that. All right. And even as you speak on placement, because it said nursing and peleko psychiatry, doesn't order. At the same time, also the role, how effective KMPDC is in terms of, because we've seen a lot of quacks. We've seen a lot of, and most people would actually go to them because either, number one, they offer cheap, services. So it's very easy for people not to really understand, are you offering quality care? But as long as it's cheap, we're going to go for them. So in terms of then the regulation, how do you make sure that, those people are actually just taken out?
Well, yes, we have developed, standards and norms that every healthcare provider or facility should adhere to. The medical professional, the health profession in general, is a highly regulated profession, and people work within certain codes of ethics and standards. For long, maybe patients or clients have not had opportunities or where they can ask questions, and that's where KMPDC comes in. As we guide the professionals in their day-to-day work through the codes and standards that we have developed, we also give clients an opportunity to come and ask questions. So we are like a referee between the service provider and the person receiving the service. So for health professionals, we have minimum requirements that they must always keep themselves up to date with the current medical technologies, treatments, because what works today may not work tomorrow, or better may come. And the way we take technologies, like, for example, telemedicine, is a platform. Where you may not necessarily need to see your doctor in person. They may treat you or provide your service remotely. And, such a technology makes it easier for those who may not have access, especially more specialized consultations, to access them from the comfort of wherever they are. For example, one at the Aga Khan University Hospital can provide a consultation to somebody in Turkana just by, the technologies that have come. So what we tell the professionals all the time is that the technology has not removed the responsibility and accountability from you. You are still responsible for the quality of consultation that is going to be provided. You are not going to blame the video camera. You are not going to blame anyone. It is you who has the responsibility. And that goes even for AI. AI can help you make a diagnosis, but you are the one making the final diagnosis. We may not regulate AI as regulators, but we can regulate the professional using AI. Remember, AI depends on a lot of data input into it. So the more it sees, the better it becomes. So, if you have AI for, let's say, the US market, is it same as for Kenya? Yet it has picked, I've just used that as an example. Most of the data that has been input there is about the region where it is being used. So even AI for Kenya will get better when probably we have information about the 50 million Kenyans in that system. Or a majority of them, we can say, yes, it can very easily diagnose TB and say to 99%. But if it was input in a country where TB is not their problem, it's highly unlikely. And so that's why we tell the professional that you are still responsible. Yes, the technology is making your work a bit easier, providing more access, but the responsibility still stands with you. As was said, the duty of care is still you. And that goes even for home care. It is just the place, location, that you're providing the service from. But it did not remove the responsibility and duty of care.
I have two questions for you very briefly, because I can see our time is far much spent and our director is about to chase us out of the studio, quote unquote. So, and please answer them very briefly. So the first one was when we were talking about, quacks and, these clinics. I don't want to believe a patient will go in and start asking the doctor, so show me your qualifications, because at this point, all they need is care. So what are some of these red flags? What is it that people need to be on the lookout for, that if it doesn't make sense, please get out, okay? And then number two, how do you then handle cases of, complaints or malpractice amongst your professionals? Very briefly, if you can.
Right, very briefly. The moment you enter any health facility, they should have prominently displayed their registration as a health facility. In addition to that, because the registration is a one-off, they need to have an annual license, so they need to have a current annual license from the regulator. In addition, somewhere they will have all the qualifications and current licenses of their staff, if need be, for you to see that. As KMPDC, we have gone a step further today. You only need to text. It's a free line, 20547, and you will get to know whether I am a qualified, currently licensed doctor or not.
Okay.
So for a doctor, you just write P, meaning practitioner, hash, the name.
Okay.
You can try with me. You'll see whether.
And see if you're. All right. The second
Then
one
for the health facilities, it is a H hash, name of the hospital or their registration number if you know it, and it will bring you back.
We can try with Aga
now
Khan.
that you can. Yes.
Now that we're here. Okay.
So the next thing is that we do continuous, inspections across the country to get any, because our law, the CAP 253 that we use, allows us to enter any health facility and confirm that it is a registered facility with registered qualified health professionals. And where we find that they are not registered is now what you call quacks. We close, we arrest, together with the agencies. So normally you'll find us when we get into a facility, we have KMPDC, we have the Nursing Council, the other regulatory bodies. In addition, there will be an agent from the DCI, the police, in the event that you are not qualified.
Okay. All right.
You are a criminal. We do that.
Okay.
We were recently in Nairobi a week ago. We are yet to visit them. We are still on the way.
Before you visit them, Prof, I can see our time is far much spent. Yes, but thank you so much for that. He spoke a little bit about innovation and also, a question still on the same. So do you want to talk about maybe the recent innovations that, you have input to make sure that quality of care, and I'll take that, I think, is your parting shot.
Sure. Yes, innovation is central to what we do at the School of Nursing and Midwifery, and we are very, very, very keen on that. We are already at the Center of Innovation in Medical Education. So basically, we use simulation education quite a lot in the training of our professionals, gives them adequate time to practice, and get it right. The other kind of innovation we are focusing on is how we teach. Like I said earlier, we use AI tools for training and teaching of our students. But most importantly, we are keen on digital health literacy. We integrate that in the course of learning, but we also encourage that our students think about technology as a form and means in which they can innovate, even as they try to look for solutions related to our healthcare system. Beyond that, Aga Khan University Hospital, our Aga Khan Health Services, our outreach clinics are all part of our clinical sites that we use for clinical rotation. And that also means that our students are able to see how, an electronic health records, for instance, works, or how the various modern digital technologies that exist to provide healthcare do come into the play.
I like that. All right, Mr. Rashid, I know my director is like, we need to go, but we can't finish without giving you a chance to talk very briefly on partnerships and what Aga Khan has done so far to contribute towards the same.
I think COVID pandemic taught us that not individual entity or a sector can solve public problems. I think the public institutions and the private institutions, they have to come together and they have been doing it for the past 60 years, like Dr. Kariuki mentioned. I think as far as we are concerned, there are doctors who come from county hospitals and other faith-based hospitals, and we train them and they go back, and hopefully they will go back and provide the good quality of care. So that's one example. Other is that during COVID pandemic, it comes to my mind that we donated ventilators, PPE and testing kits to other faith-based and private public institutions. I think that partnership should continue. And the third aspect, which is also very close to our heart, is the research agenda. I think we have been, Dr. Kariuki mentioned it indirectly, that we have been the consumers of knowledge, not the creators of knowledge in this part of the world. I think the private institutions and the public institutions, they have to come together to invest in research agenda so that the artificial intelligence can have the data, or the database have the data of our population. This is just one example.
I like that. And of course, we all know Aga Khan is very rich in research as well. Unfortunately, our time is limited. We have to end it here, but we can continue the conversations amongst ourselves off air. We are literally being chased out of the studio, but you can tell us.
A very quick one. You asked about how we handle complaints.
Yes.
And we receive complaints from everyone, the public and even health professionals, about something that they would want to get answers about.
Yeah.
Once we get that, we help them to get to a determination on whether there was merit in the complaint or not. If there was, then maybe they get into a discussion on how they can compensate one another if it is compensation. It could even be just saying sorry.
Sometimes, yes. Sometimes,
yeah. Not necessarily financial. For the professional, then there are ways of what we can do. We can ask you to get retrained if we think that was the problem. We can give you a warning. We can suspend your license. We can deregister you if it was that bad. Such things. So everyone, the public and professionals, and we are very fair to all of them. Those who have visited us know.
Okay.
Yes.
All right. I see that. And we'll continue this conversation. It really doesn't have to end here today. We can have more of this conversation so that, again, like we said, we really improve on the quality of care and professional standards right here in the country. But for now, allow us to say thank you. Thank you so much for your time this morning, Mr. Rashid Kalani, who's the CEO, Aga Khan University Hospital, Professor Eunice Ndirangu, Dean, School of Nursing, right here at Aga Khan University Hospital, as well as Dr. David Kariuki, who's the CEO, KMPDC, and to our lovely, lovely audience as well this morning. Thank you. Thank you so much for your time in being with us. And we're taking a short break, and then when we come back, we'll also talk about more on the story of love beyond all seasons. And in this case, we'll be talking about a couple who went through cancer. Okay, you do not want to miss that part of the conversation. Do stay with us. The show is Your World.
We have 1.4 million people living with HIV in the country. Over the last decade alone, we have reduced the number of infections by almost 83%. Government reformed the National AIDS Control Council to the National Syndemic Diseases Control Council so that we can also take on board other diseases that accompany HIV. Over the years, we have had a very robust program responding to HIV, supported by both the government and partners. But we have also been put on a notice by our development partners, by our colleagues, the US government, the Global Fund. As a globe, we have committed to ending HIV as a public health threat by the year 2030. So as part of our journey towards resilience and sustainability, then we need to look at better mechanisms of running programs which reduce operation overheads and enhance the resources that are available for service delivery on the ground. We have made strides. We have made progress. But we must not confuse progress with success. It costs about 15,000 shillings per year to keep one on ARV treatment. About 1.4 million Kenyans who are currently on treatment. Kenya needs about 25 billion shillings. We are speaking to people living with HIV also as communities to lead from the front so that we can invest more and get more, harness more benefits from prevention rather than from treatment and care. And that's why for us, the Nation Health Summit is a very special opportunity for us to continue this discourse and accelerate our progress towards 2030.
One of the greatest midfielders of his generation, the genius of Kevin De Bruyne turns football into an art form. Known for his passing, creativity, technique and venomous shooting, De Bruyne was the elegant architect behind Manchester City's golden era. But after a decade of glory at the Etihad, De Bruyne's time in Manchester is drawing to an end as he weighs up his next move.
There seems to be a recurring issue here. Anger.
I don't think I have an anger issue. I think you got an anger issue. Are you aware that that robe that you're wearing isn't fooling anybody?
Voila!
Oh my God.
Hotel Transylvania.
Sir, we have an urgent plumbing issue.
Plumbing?
There is a clogged toilet in room 348.
Whoa! A human!
There's one thing I know about the world. It's not the little things that matter. And we played Don't You Shoot.
Bella, don't you shoot.
That one was his favorite. Together.
Jumanji. Every house has secrets.
Everybody in town thinks the place is haunted.
But what happened in this house?
Little Alan Parrish. He just vanished about 25 years ago.
Is a mystery that began a long time ago.
And just when I thought my inventing days were over,
It really works! I love it!
Cloudy with a chance of meatball.
Where's the jungle? This is a whole new thing. Nobody told us we had to do a whole new thing.
Okay, something went wrong.
Terrible driver. What are you talking about? I just passed my driver's test last month again.
Tired of endless scrolling? Say goodbye to the chaos. Introducing the all-new Business Daily website. Experience seamless navigation. Immerse yourself in a world of more videos and more podcasts. Discover more with our enhanced home pages. Engage like never before with our interactive tools. Join us and elevate your reading experience today. Business Daily. More possibilities.
We had tremendous increases on the mortgages that we disbursed to the market last year. We did, almost 5 billion out, and that in itself is a significant increase. In our view, we think the markets are beginning to have a correction. At the moment, the short-term rates are single digit, which is great. If the same trend continues for the medium-term bonds, then certainly by the end of the year we'll have more clarity. We have been having engagements with IFC and a number of other financial institutions that are keen on green finance, green mortgages.
Reach your audience instantly and make a lasting impression with Nation Sema. Affordable bulk SMS at 0.3 Kenya shillings. Own sender ID for 10,000 Kenya shillings plus 10,000 free messages. To sign up, please call 0728434979 or email us on mkibunja@ke.nationmedia.com.
Welcome to Sun Park Residence, a premier-gated community on Chadi Road, off Mombasa Road, just 800 meters behind Gateway Mall. Discover spacious 1, 2, and 3 bedrooms ready to occupy and off-plan apartments for sale, starting at just 6.5 million shillings. Contact us on 0793 444 222 to book your unit.
Welcome back to the show. The show is Your World, and we are in the second hour of the show. And this morning, we want to speak to a very lovely couple that I have with me this morning, and they want to share with us a story about how love, you know how they usually say in church, for better or for worse, in sickness and in health. So they're sharing their story of love in all seasons right here with us this morning. And this is after a diagnosis with cancer. How are they doing right now? How did this strengthen their relationship? Well, They are here. So let's find out. And we have Brilliant right here beside me, Brilliant Cherono Gitonga, who is here to share her story. So Brilliant, thank you so much for making the time. You look lovely. I like this color. It's very, very beautiful. You look amazing. And we have Dennis Gitonga, who is Brilliant's husband, joining us this morning on the conversation. Hi, it's good to see you. How are you doing?
I'm fine, thank you.
I like how you're seated. It's like I'm the gentleman of set. Thank you so much, you guys, for making the time. Before we even talk about cancer and diagnosis and your journey through it, let us go back, way, way, way back. When did you guys meet? How was it? How did you guys fall in love? I like such stories. Before we talk about this other stuff, Brilliant, do you want to go first?
Yeah.
Okay.
We schooled together in the university.
Oh, so you guys are university sweethearts?
Yes.
Oh, okay.
Yeah, so we started a relationship in 4th year.
Okay.
Yes. Yeah, he proposed to me in a bus station.
Really? Wait, how long after you guys started dating did he propose?
He just proposed once. Like we didn't date then. Yes, proposed for marriage. Yeah, when he talked to me, we were friends, not very tight friends because we were in the same committee.
Okay.
We were serving together. Yes, but then there's one time he says, "Would you consider to be my wife?"
And you said?
I said yes. But I think he was not ready for my answer, so he didn't give me time to explain or to affirm. And he gave me 2 months to give him the answer.
Wait. So he proposes to you at a bus station.
Yes.
Okay.
Yeah.
You say what?
Someone asks you a question.
Yes.
And I say, yeah. So before I continue to say what I want to say, he already decided to give me 2 months to go and think about it then. I think alikuwa na script.
Right?
Yeah.
It was like, hey, so Dennis.
Yes.
So you saw this lovely lady in campus and you say, this is the bone of my bones, ribs of my ribs, bone of my
flesh of my flesh.
And then you say, this is the one. How long ago, after when you guys started dating up until you decided to propose, how long ago was that?
Well, I think it took like, from the time I asked the question.
Yes.
It took like about 2 years. Because we did that in the year 2012.
Yeah.
And, no, 2012, yes.
Okay.
And then we wedded in 2016.
Okay.
Yes.
Okay. So you took some bit of time.
Yeah,
so what she's saying is you didn't date. Yani ulimuona kwa sababu wewe the wife. You had decided.
Yes, you see, I had been with her since first year.
Okay.
We had met in different forums.
All right.
And we had interacted. I had been able to observe the kind of person she was.
Okay.
And at that time, I had been trusting to be able to get someone that I could actually marry.
All right.
And so when that time came, she had ticked most of the boxes. And so I thought, well, she should be the one. I actually took time to think about it.
Okay.
So when I was proposing, or when I was asking her the question, it wasn't something that I hadn't taken time to consider. It was something I was ready for. And, well, she's talked about the bus station.
Yes, I want to know about that.
Well, I had actually planned to propose to her in a hotel.
Okay.
But then, guys, this is what happened. We met. I actually invited her for lunch.
Okay.
She said, I'm okay. I don't want to take lunch. Okay. I brought it lower.
Okay.
Can I invite you for a cup of tea? She said, I don't think so.
This one is just a wing plan.
Yes.
Okay.
You know, how do you go about it? So finally, she agrees after I insisted. And then when we went, I discovered the place I had set for it was not very conducive. So I wondered, okay, do I continue with this or not? And when we had exited, I felt, I can't live without asking her. So whatever happens, let me pop the question.
Yes.
And so I decided to pop it where we were.
Bus station ya wapi? Kencom.
LD.
Oh, Eldoret. I thought it Kencom up in Nairobi.
It was in LD. We were in Moi University. So LD was the place to go when you really needed to do something big.
That's
that
beautiful, though. That's a beautiful story.
Yes.
Were you scared? Like, we go to bus station and then this guy, did you go down on one knee? Okay.
No, he just asked the question.
Okay.
So I wasn't scared, really. I think it was also at a time where I was trusting the Lord to guide me, whether He would want me to be in a relationship or to wait. So I'd actually planned to pray and fast. So that God will lead me on really what He wants with my life. Because earlier on I'd had several people proposing to me, and I was like, hey, okay. Sasa nani ni nani?
Hey, you had options.
Yes. Yeah. But there were others that were annoying because I would get even married people proposing to me. So I felt, I don't want that. Yes. So just before I did the prayer and fasting, he proposed. So I knew.
You didn't even have to pray. God answered your need.
Yes.
Okay.
Yeah.
And then got married in 2016. Okay. Let's talk about life between 2016 and 2023 when you got your diagnosis, right? At that point. How was life? How were you guys doing, kids, at this point, between this period?
Yes, we were doing well. Living normal life. We were happy with each other, doing ministry together, starting a family, adjusting to marriage, growing together. Yes, by the time we had the diagnosis, I was expecting we were expecting our third born. Yeah, so basically life was going on well. Yes, and yes, this was not, the disease was not one of the things that I would really think, or it would even cross my mind, really. Yeah.
Okay. So everything was okay. Family is good, everything. So do you have any symptoms? What was happening? And I want you to answer based on what you had seen before now both of you went to the hospital. Yeah.
All right. As far as symptoms are concerned, or our life before this time.
Yeah.
Well, I would say we were enjoying life as a couple. We loved traveling. We were doing events and meetings and camps and conferences and many, many things. We love visiting, so we'd do a lot of visiting. We'd host a lot. We were enjoying life, basically. So when this moment came, we were actually trusting God for our third born. And so it had just been confirmed that we are expecting our third born. And then, one moment, she tells me, there's this small thing that I've been feeling, very small lump that I've been feeling, and it is worrying me. And we are talking, and I tell her, well, don't worry about it. The next moment we go to see a doctor, we will be sure to ask about it. And so we were due for a clinic for of course, the mother and child health. And so I thought that would be the opportune time to actually ask the doctor what he thinks about it.
Yeah. How far along were you, pregnancy? I mean, it was just...
I was in my first trimester still.
Okay.
Yeah, so about 10 weeks. So we went to the hospital. And yes, we raised the concern with the physician there. But then apparently when, because I was diagnosed with breast cancer, during pregnancy, the breast also changes. And so they can't outrightly say it is this.
Sure.
Yeah, so the doctor said, because you are pregnant, it is possible. It is just the normal breast changes during pregnancy. So let's wait and see. When you come to the next one, we will see how it progresses. So that was what we were told. Yes, unfortunately, when we came for the second and the third, we did not find the same physician. we kept finding a different person. I think there is a challenge with consistency unless you're going to a specific doctor. Yeah, so by the time we are getting back, that one was in January, the time I got the small lump, which was very, very small, like a green gram.
All right.
It was small. But then by the time we're coming back in April, it was really big. It had really grown.
All right.
Yes.
Okay. So how concerned, Dennis, are you at this point? Because several aspects to it, and we were talking about this earlier on in the first part of the show in terms of access to quality healthcare, and human resources such a big factor, where there's shortage, of physicians here and there. Now, to hear what she's saying, that every single time you went to the clinic, you find a different person. So you have to go back to your story, try to explain to them, this is what I was. How concerned were you at this point?
Well, I was worried because this could be anything.
Yeah.
And most of the time, because we've been exposed to information about cancer, and especially to do with breast cancer, you're told if you feel a lump, then this is a warning sign, or this could be cancer coming. So at that time, you're really praying that's not it. And so I was at a place, well, I don't want to conclude. I would rather hear the doctors. And so I'm concerned that it doesn't turn into that.
And then there's a baby on the way as well.
Yes. So it's just a whole confusing status or state of things, because you are excited. And then in the excitement, there's this worrying news that is coming. And the fact that it was really worrying her was, for me, something not good. And so I really looked forward to the day that we'll meet the doctor, so that she can have peace. And she can be in a position to raise a baby in a peaceful manner.
Absolutely, and understand what is happening.
Yes.
So 3 physicians in, right? So at what point then did you have the diagnosis? Because again, like you said, since the first time you went to the hospital and explained what you were feeling, and by the time you saw, the second and the third physician, it was growing, right? So at what point then did you receive the correct diagnosis?
In April, I started feeling some, what would you call it? Uchungu. Yeah.
All right.
Some pain at the nipple. So it really got me concerned. I thought maybe I'm developing mastitis. And you see, I went to Dr. Google. Unaona hizo symptoms zinakaa tu kufanana.
Yes.
Yes. So we decided to rush to the hospital. Okay, to go to the hospital. We really didn't rush. Really, we went in the middle of the night, because the following day I needed to preach. And so we were like, want to go to the hospital now, so that we know what we are dealing with, so that in case these symptoms persist or become worse, then he can be able to look for standby or speak on my behalf. So we went to the hospital at night. Was examined. Then the physician said, okay, I think you need to do a scan. So I did the scan the following day. When I did that scan, then there was it raised some eyebrows, because it showed that my lymph nodes were enlarged, yet they were not painful.
Oh, interesting.
Yes, so he said, okay, I think you may need to see the gynecologist, since you're expecting, to see whether this is a normal pregnancy occurrence. Yeah, so we booked an appointment with the gynecologist. So when we saw the gynecologist, she examined me, then said, okay, normally when I have clients who have breast issues, I have a friend who is a breast specialist, so I just call her to
help and figure out what is happening.
What it is. And so that's what she did. And then the specialist proposed we go to her clinic for her to be able to examine. Yeah, so we go to the clinic, and she says, looking at this, I think you may need a biopsy, because we don't want to be sorry. It's better to rule out or not conclude when it's not it. So, yes, we were sent for a biopsy, which we did. Yes, and then we got the news in May. Yes.
Perhaps I should add that at the moment we were having these visits with the doctors, one of the key things they were suspecting would be a mastitis.
Okay.
And so there were 2 doctors who actually thought, even the sonographer thought these are signs of a mastitis.
Okay.
And were it not for the fact that the lymph nodes were not painful, we would easily have been treated for mastitis.
Yes.
However, they still did treat for mastitis just to rule it out. And we were given a protocol for like 2 weeks to take for mastitis. But then, of course, by the time we are coming to the breast specialist, she observed the need for biopsy, but still gave us another protocol for mastitis,
again,
just in case that could be the issue. But I think she knew more than she let out at that moment, but she just wanted to ensure that we go through the process and be sure from the, the lab results and all those things that they do. Yeah.
So you received this. So how far along at this point, like when you're receiving the news that, listen, this is
so we did biopsy in end of April, and then the results takes 21 days. Yes, so it's 21 days of waiting. And a waiting period is not
It's not easy. It's not
nice.
easy.
It's just but God really helped us through that season. At the time when I went in for biopsy, because I was really scared, I didn't know what to expect. I was afraid of Googling.
You always get what you're looking for.
Yes. So I don't want to be too scared if I don't need to. But then it's not as scary as I thought. So when I went in, and my husband was not allowed to go in with me, he remained outside, and I told him, I'm so afraid, I am anxious. Please pray for me when I go in. I don't know what to expect. So he was left outside to pray. And as he was praying, he got this word, Psalm 91.
Okay.
Yes,
I love Psalm 91.
Yes, Psalm 91.
Yeah.
So when I came out, he read to me Psalm 91 while in the car. And for the 3 weeks that we were waiting, we read Psalm 91 every day to just encourage ourselves and give us hope. Yeah, so that really kept us... until the day we were told now.
Yeah, this is cancer.
Yeah.
So what is going through your mind at this point when the doctor says, well, this is cancer? And how far along in your pregnancy are you at this point?
I was 32 weeks pregnant.
Okay.
So there were 2 news that I received that day. She said there is a good news and a bad news. Which one do you want to receive first? We said, give us the good news.
Good news. I mean, at the very least, yes.
Yeah, so the good news was that the pregnancy will not be terminated. No. At least I will be able to give birth. We came to know if at 10 weeks when I noticed, if it was diagnosed then I would have my pregnancy terminated. So we were really excited that at least this baby will live, will have a chance to live.
Yeah.
And then the bad news was that now you are, what we thought is actually.
And what stage?
So we did, at the announcing, they don't give the stage, you do the staging. So we did the staging and it came at 2C, I think.
Okay.
Yeah, but then I had time to wait because I was expecting.
Yes.
So I waited from May. I gave birth in June.
Okay.
Then, because I gave birth through CS, I needed to wait until the wound is healed because I couldn't do chemo with wound.
Yeah.
Yes, and then in August, we did another restaging because it had taken like three months
after the
diagnosis.
Yeah,
so we need to do restaging because many things could have changed.
All right. Can we put a pause there?
Yes.
Because it's a lot of waiting in this case, which again we'll talk about after the break in terms of, because like you said, if you got the diagnosis when you were at 10 weeks, unfortunately, the pregnancy would have been terminated.
Yeah.
But you got the diagnosis at 32 weeks, and then you had to wait until the baby is here before you start.
Yes.
So all this waiting game, quote unquote. I want to hear from you. How were you doing? How were you dealing? Because you have to be strong for her, not just for her, but also the baby you're expecting. But you want to answer that after the break?
Okay,
all right. So do stay with us. The show is Your World. There's so much to discuss on the other side of the break with these two lovebirds right over here to help us understand how they were able to go through this difficult moment in their lives, but also at the same time, a good moment because a child is here, a child is born. So navigating that as a couple, we do not want to miss the second part of their story. So stay with us.
Our relationships are not working.
Femicide. Ilikuwa tu vitu zinafanyika, mnanyamaza, zinafunikiwa.
Nobody deserves to be killed in the name of relationships that are voluntary. If you don't like me, just leave me alone.
Sisi kama wanaume pia kuna vile tunakuwa affected, but tunanyamazia juu machozi yetu ni ya ndani.
Today I feel like we are lifting the lid. We are lifting the shame. We are lifting the conspiracy of silence that men can actually talk.
Marriage is a journey.
Whoever can annoy you, they can control you. Don't allow a woman to annoy you. If she starts pulling you down, my brother, just walk out.
Pata taarifa teke na e-paper. Stay in the know on the go. Getting the full story bila ngori. To sign up, choose your preferred subscription. Use the promo code SUBZ22 to get 20% off and pay. Get your favorite newspaper and enjoy the truth anywhere, anytime. For inquiries, email epaper@ke.nationmedia.com or call 0790 111 111. Subscribe today and get your taarifa teke.
June 15th, 2025 is Father's Day. The 14th of June, a day before, will be a day for Man Cave 5.
And only men are invited, eh?
It's the day when men will be coming together at Herencia off Thika Superhighway, just 2.5 kilometers. Just before you get to Mangu High School, you turn left and you come here, and men will be congregating here for heart-to-heart conversations.
And only men are invited.
Yeah, men will be sitting down and having one-to-one conversations. I will be one of the MCs, and my colleague Brian Aseli from Nation FM will be the other MC. And men will be sitting down so we can just talk heart-to-heart.
And only men are invited.
Yeah, only men are invited. Buy your tickets today on kenyabuzz.com.
Aiden, please, ongea na kakako, please, mwambie punguze hasira.
Hivi unajua ni mama's boy wangapi wamekuwa kwenye haya mahusiano and they never work?
Umefika wapi?
Do you know how difficult it is to balance these things? Huh? Are you out of your mind?
Nakuja hapo na Cecilia. You better watch out.
When I have back pain, I reach for 2 tablets of Panadol Extra for fast relief of strong pain like headache, toothache, muscle pain, and I am finally released from pain. Try Panadol for fast and effective relief from strong pain. Now available at an affordable price.
I'm a clinical director here and I look after everything
regarding the patient's consultation, ultrasounds, the procedures, IVF, and everything is available under one roof with all the latest facilities. And we have been running this center successfully now for last 3 years. There are a lot of tubal blockage cases which require IVF, because once the tubes are blocked, they cannot have natural pregnancy. So a lot of people don't know that it's available. And then there are a lot of other issues like the young girls who are studying and who are delaying pregnancy for whatever reasons. We want to create awareness amongst them that the egg freezing is a very good thing to stop the biological clock. We decided to participate in this because we wanted to create awareness amongst the people as well as the health professionals that the sexual health and the treatments for infertility, etc., the advanced treatments and the specialized doctors are available in their country. Everybody should attend this kind of health summits so that they are aware about the things that are available. We want to basically offer them treatments at the affordable prices so that they can have their families and they can live happily.
Welcome to Sunpark Residence, a premier-gated community on Chadi Road, off Mombasa Road, just 800 meters behind Gateway Mall. Discover spacious 1, 2 and 3 bedrooms ready to occupy and off-plan apartments for sale, starting at just 6.5 million shillings. Contact us on 0793 444 222 to book your unit.
All right, welcome back. 31 minutes past the hour, and the conversation is on love against all odds and in all seasons. And we have an amazing couple with us this morning to let us into their story as far as after a cancer diagnosis and how they were able to maneuver through. Because on one hand, there's this terrifying news, but then again, on the other hand, there's also this good news that they were expecting a baby. And there's a lot of periods of waiting in your story. And of course, morphing through, this season and being here today, stronger together. We say thank you for agreeing, first of all, to share this story with us. We have Brilliant and Dennis Gitonga who are here this morning to share their story. So we were at a point where, you got your diagnosis, but had to wait until the baby is born before you start chemo. And we're talking about how waiting. How are you doing, Dennis, at this point? As the pillar of strength for both her and the baby.
I'll start with the waiting outside.
The waiting outside, yes.
The biopsy process.
Yeah.
So she mentioned that I was hoping that I could actually get in so that I can see the process. Mm-hmm. But the doctor said, no, you can't. Mm-hmm. And so I'm there tensed, anxious, nervous. Mm-hmm. I had hoped that I would be by her side at least to encourage her. Yeah. But now I'm alone. I don't know what will happen. And so I'm there left asking God, what do I do now? Yeah. I'm blank. Mm-hmm. I don't know exactly what to do. And as I'm thinking about what to do, I feel the need to pray. Mm. But then, how do I pray? Yeah. I've already prayed that this thing goes away, that it is not what we are thinking or suspecting it is. But then, we are here. So that's when God dropped Psalm 91. And I started praying along that, from verse 1 all the way. And as I was doing that, I was feeling this is actually speaking to exactly what we are going through now. So for me, at this time, I'm really hopeful that even though we have come to this point of testing through that biopsy process, that eventually the results will be favorable to us.
Yeah.
But then fast forward 3 weeks later, the results are not favorable. I was the one who went for the lab results to get what they were thinking. Yeah. And so I have them in an envelope. And I'm wondering, do I open fast and see what the doctors have written or the lab guys have written?
Set your buffer by the time you're going to deliver the news.
Yes.
Yeah.
I'm prepared.
Yeah.
Or even by the time the doctor is giving the news, I have capacity to support her. And so I was avoiding to be the first to get the news.
Okay.
But somehow, as I was getting to the health records area, I just thought, well, we are going there, at least we still get to know. And I just got a glance of what was written there, and I saw inductive ductal carcinoma. And I was not so sure what that is. But then I knew the carcinoma thing. That one sounds familiar. I've had it in movies. That thing that ends with Norma. Those things, Norma. So I saw that, but I thought, let me not rush into a conclusion. Let me wait for the doc to give us. And so when we are getting there, all tensed up, I'm really praying that things don't go bad. But the doctor was very good in preparing us. She asked us, what are you prepared for? What are you hoping? And she just weighed where we were. And then now came to break the news of, I have bad and good news. Yeah, so that was the situation for me.
Oh man, I can only imagine. I can only imagine how that was for you. So at this point, when you're told, so these are the options. We wait until the baby is here before you start chemo. But now at this point, do you know what type of cancer it is, and also at what stage?
Yes.
Because, like you said before we went on a break, it had spread, right?
Yeah. So when they gave us the diagnosis, by God's grace and favor, we were able to do staging on urgent basis since I was expecting. So I really didn't go with the queues. God just intervened, and I was able to do the staging. I needed to do 2, a chest CT scan, and then an MRI, because I couldn't do MRI chest and abdomen since I was expecting. I couldn't be able to lie on my back for long. And then I couldn't do CT for both since I was expecting. The baby needed to be shielded. So God just intervened, and we were able to do that in actually following each other. I went to hospital on Wednesday, on Thursday, and Friday. Yes, then the following week on Wednesday we were given the results. It was both good and bad news. I think God was gracious to us to always provide us with good and bad news. So even when we got the bad news, there was good news, and that really kept us hopeful. One of the things that we adopted as a family is reflecting about how the day went. So after the day, which used to run from 6, actually from 5:50, because that's when we would leave from the house, until maybe 7 at night, because the queues sometimes can be crazy.
It's not good.
So when we got to the car, we would reflect, how has the day been? And yes, I think I'm the crybaby, so I would cry about the bad news. But then after that, would say, then what was the good news? What do we appreciate for that? I got these results. I was able to see the doctor. So those things that you may really take for granted. That I got a doctor that talked to me well. I got a seat. I didn't stand all the time. So we would basically look at the day and the nitty-gritties, and then we would pray about it, and almost all the time we went home happy. Like having settled, there's a bad news, but there are many good news.
Very good news.
Yes. So by the time we were getting even to the children, I think most of the time they even didn't know what was going on.
This was your third baby, right?
Yes. So I have a 7-year-old, a 4-year-old, and now this one is 1-year-old. So we would go home smiling. Because we had those celebrations also.
All right. So you want to contribute to that?
Yes, I want to chime in on the bit of the situation. Sometimes we'll go to the hospital, and one of the greatest things that we had as a blessing, and we've had throughout our journey, is friends. friends that are just situationed at the right place.
Yes.
We have one of the hospitals we've been going to, quite a number of guys are friends. We have like, I think 5 or 6 people in that hospital that are friends. We worship together in church. And one of the things that happened is that they would be very much helpful to us. Either talk to us, get to know how the situation was today, where we need assistance, they would be able to offer that. You know, talk to us even after the day is done. And that was a great blessing to us. But even beyond the hospital, we had people all over the place, calling, texting, and, you know, just checking on us. The other thing that was very instrumental was music.
Okay.
Yeah.
All right.
Music.
Okay.
I love music, and both of us enjoy music.
Yeah.
And there are those times you don't know exactly what to do. We are Christians, and we are thinking, I need to read my Bible. I need to pray. But sometimes you don't have that strength.
Yes.
Sometimes you don't know exactly how to pray. You've prayed, God knows what is in your heart, what is in your mind over this matter. So music was very critical, even right in the hospital. I remember there's a day we went, we had come from church and we were headed home, and then she starts feeling bad. And we actually take an about turn, go to the hospital.
Go back to the hospital.
And we're in hospital and she's feeling all these things, and the doctor says we need to have an echocardiogram performed on you to check your heart.
Yeah.
And we're wondering, why does her heart need to be checked? You know, what's the problem?
Yeah.
And then she's in a lot of pain. And they gave her some very high dosage of you know, one of the strongest painkillers to just calm that down.
Yeah.
And as we were walking along the corridors of the hospital, they have TV screens. Some songs came up. Asikia maombi. And that one was making us feel, oh, the Lord is hearing our prayers. And a number of songs came right at that moment, about 2 or 3 of them, that were ministering to a particular situation. And countless times we've been encouraged by songs. There's a day she actually, the day she lost her hair as a result of the chemo. And she was crying. She invited one of her friends to come and just be with her. And she's wondering, what do I do? My hair is falling. And it was like, all of a sudden, the hair is going.
And it's gone.
It's gone.
Like it goes, you know? At once. You remove it like a week.
Yes. All of a sudden, you're thinking katatoka kamoja hivi. Then it's like a kofia. Gone. And that time, the Lord ministered to me with a song. And this song was saying, But thou, O Lord, art a shield for me, my glory and the lifter up of my head. And I remember the verse that says that the woman's glory is the hair. But then at that very moment, God was saying, well, it says hair, but I really am your glory. So that even if your hair is gone, I still am your glory.
Wow.
And that was a bomb for us.
That's really beautiful. Wow. So baby is here, right? Through CS. And then you have to start chemo. At what stage? Stage 3 now? At this point?
But by the time actually when I gave birth, I had like 6 weeks before I start treatment. And so those days, the first few days were really bad because again I was waiting for another test called FISH test that takes like 3 weeks. That was actually done in Aga Khan. So it was a moment of waiting. You don't know whether it will turn positive or negative again. So I would just wake up sometimes and cry almost daily. And then at one point I just got tired of crying. I said, I'll not cry for 6 weeks. I mean, it really drained me up. And then I realized I'm not celebrating my baby because I'm always sad and thinking about this. So one time I just said, God, you know what? The doctors have said there's nothing they can do. For now, we do not have anything we can do. We don't know what we can do. But one thing I know, you can be able to do something.
That's true.
And whatever you decide to do, I am okay with it. You can choose to heal me. You can choose to stop this thing where it is. And you can choose for it to spread. It's okay.
true.
Like, I have no control.
Yeah.
So after I made that prayer, my heart just settled. I didn't cry again. I said, God is in control. Whatever you choose, let it be, because you are God. And amazingly, after a few weeks, the lump just shrunk.
Really?
Yes. It just shrunk. It became small. And I know that was able to be, like, it was scientific, proven. Because when I did the first staging, it was at like 6 centimeter. And then when we redid the staging, it was at 1. 1. So God just encouraged me. And now that time of waiting was amazing.
Oh, that's beautiful. So then what course of treatment did you go through? What course? So you did chemo?
Yeah, so after that, after the diagnosis, I did chemo. I had 8 sessions. For another medicine, then for another one. Yeah, so I did a total of 8
sessions.
Then after that, we needed to do surgery, which apparently delayed because of the strike year 2024.
Oh, I know, yeah.
Then I did surgery in June. I finished chemo in Feb, then I did surgery in June. Then after June, I needed to heal, then go for radiotherapy. Around the breast area, the chest area, and the neck. But then I wasn't able to do that because after I came from the hospital, I developed a backache. We thought it's an issue of posture. We went back to the hospital. They recommended we do physiotherapy. Am I saying that? Yes, physiotherapy. Yes, so we did physiotherapy, like 6 sessions, and every time I went, it would worsen or move from this side to this side. So one time I needed to now go for ACT planning, and by then I was actually on a wheelchair. I couldn't walk. So I made these radiotherapies, and he's asking, why are you on the wheelchair? Which surgery did you do? I say, it's breast. How long ago? It was like 6 weeks. No, you shouldn't be there. In fact, when the surgery you did, you were just supposed to walk that same day, which was true, because I actually was walking that day. So he recommends, I think you must see a consultant. He must review this pain. So we go to the consultant. He decides to call to explain why he is referring us there. And when we went, we do a scan, and it says now it has spread to the bones.
Oh, no.
Yeah, actually, the reason as to why you can't walk, it's because now it is on the spine. So the lumbar spine and the neck. So what do we do? It's an emergency radiotherapy, because if you continue like that, you'll not be able to walk.
Completely,
so we did radiotherapy on the spine. So there was wakasema hii ingine ya breast si emergency, sasa hiyo itangoja. Ingine ni a matter of life and death. So we did radiotherapy there.
I see that. And you sitting here, I think that's why you're asking her, are you comfortable? Are you okay? Do we move the seat down? Now we understand why. I can see your time is far much spent, but I want to understand. So went through radiotherapy for how long? How many sessions now?
I did 10
sessions.
5 at the neck, 5 at the lumbar.
All right. Okay. And after all those periods, how are you doing, overall?
I think during chemotherapy, it really didn't strike me much. I would attribute that to a positive response, I realized when you accept the medicine accepts you. Kinda. When you refuse it, when you just say, I don't want it. And we had, or rather we would find other patients. And I remember one of them that had refused. Actually, she wanted to die. But then one time we like when she saw me, because I used to be just the way you see me now. I was glowing, and many times we'd go to the hospital and they ask us, who is your patient? Then
they were like,
me. And they're like, oh,
no, you can't.
Are
be
you
the
sure?
patient.
See. So we just decided if this is what God wants us to pass through, then we can trust Him, and it gave us strength. Then people were praying for us again.
That's
strength
that they talked
yes,
about.
and every time I felt I'm strong, I knew someone has prayed somewhere that I be strong, and that was really our prayer.
I like that, and that support system.
Yeah.
So having gone through this process, first of all, now you are on.
So right now I'm on hormonal therapy and targeted therapy.
Okay.
Yeah, because after radiotherapy, I had very. I think the radiotherapy is after surgery. That's when the journey became tougher, because now here you have a real pain.
Yes.
And then so I was having pain at the surgery site, and then now I'm having pain on my back. I told you there were times I couldn't walk. I would walk with support. A lot of support and a lot of pain. I did very strong painkillers, and still were not really helping. Then after radiotherapy, I had very bad side effects. I think because the Nini was done on the neck, it affected my brain. So my functions, the brain functions just went like, I got psychotic depression. There was a time I did not sleep for almost a week. I can't sleep. They inject me dawa ya kulala, and I don't sleep. Yes, even an overdose, and bado sikuwa nalala. At some point I couldn't chew. My jaws just refused to chew. At some point my speech was affected. I was talking with a slur. Like, you really had to, what are you saying? There were things that, again, zilikuwa, even people would not hear what I'm saying. So at that point we went to the hospital, and the doctor was like, why is your speech like that? So we did another CT. Actually, we did a CT. At the time I got psychotic depression. Nilikuwa nimekuwa mwendazimu of some sorts for like 3 weeks. That one I think my husband will talk about it. Because at that time I wasn't myself. Yes, he says I would be myself and not myself.
But not yourself at the same time. I hear you. We literally have like a minute before we say, I know time really flies. But, going through all this, but at the same time, a new baby, at home, and also your other children, and they're wondering what exactly is happening and all those things. How were you able to, stick together, stay strong, go through all these phases, up until now where you're here together strong and, sharing your story as if it's just me, nilienda mtoni, nikachota maji, like it's not a big deal.
Well, it takes a lot of intentionality. I would say that, because when you're faced by such a matter, one of the things that will happen is you'll be very shocked. Sometimes you'll be in denial. You're not thinking, no. This thing can't be happening. And I remember moments I would be in the hospital streets just alone, because she would be seated and I'm trying to run through the processes. And I'm just trying to imagine, is this real? And there are times when I would have to stop tears flowing, because she never saw me cry. But there are many times I had to stop the tears from flowing for her sake. But then being there for one another was something we had committed to each other when we were beginning our marriage, for better, for worse. And there are many things that would have made it very hard for us to continue. But God gave us grace. I would say the first and foremost thing is that we had faith in God, that regardless of what we are going through, He is able to get us across the river to the other side.
I really like that,
And then though all these family and friends, as I mentioned, were right there sticking with us through it. And there are so many of them, I'm not able to mention.
We can't
names.
mention them because unfortunately we have to end the show. But you want to speak in 10 seconds to the lady who's watching us and thinking, how am I going to go through this? All right? 10 seconds before to fukuzwe.
Thank you. One of the things that I think has kept me strong is, as we have mentioned, faith in God. Yeah, many scriptures just kept coming, saying God is a healer, and we say, yes, we want to put our trust in this. You can make it through. God is with you in the season. That was really a very encouraging bit for me. And then knowing that I actually have to fight, I got to hear from people who have been warriors. So through friends connected me to people who would give a testimony of how it looked like. And one of the things that I gathered through that was you have to fight. You have to fight. People will come and strengthen you, but you'll have to fight. You'll have to say, I want to go through this and I want to be a victor. I just don't want to sitakubali nilale kwa kitanda the whole day. I want to pick up myself, even if I will need support, and at least walk. So you have to fight again. Yes. And then the support is really amazing.
It's very important.
Yes.
Yeah. We need to have you guys back so that we finish on this other part, because you talked about psychosis and all those things. Please come back and so that we finish on that part, because we literally have to end the show now. But we appreciate your time today.
Asante.
Such a powerful story to share with our audience. For them to know that, listen, you can do it. You can fight. And
you can do it.
And you can glow. Look at her.
Yes.
Come
and
out
there are
on the
many
other side
victors,
stronger.
actually. There are many people. There are many good stories. I think we've always heard about the bad stories.
Yeah.
I think there are many good stories than the bad
out
stories.
here, including yours.
And I am
very
a
powerful
testimony.
story. All right. Yeah. But thank you so much.
Thank you.
For coming by today. We look forward to talking to you guys in another setup now to finish on the other side. But for now, I'd also say thank you, brilliant Cherono Gitonga, as well as Dennis Gitonga, sharing their story with us this morning on Your World. My name is Winnie Lubembe. Enjoy the rest of your day. We'll see you tomorrow on Relationship Tuesday. Until then, stay safe and God bless. Goodbye.